aware of that. We will be able to share with you the link for this presentation. And the next voice that you will hear this morning will be Dr. Nose. Thank you, and we will be taking questions, so please use your chat box.
Good afternoon, everybody. Thank you, Deborah, for that introduction. I'm excited to be here and to share with you all a little bit of what I know about implementation science and how we can use that to close the treatment gap. I'm a clinical psychologist by training, and I'm also a professor at the Community Health and Social Science Department at the School of Public Health at CUNY. And I also direct the Center for Innovation for Mental Health. And much of the work that I've been doing over the last 10 years has been focused on implementation of evidence-based practices in mental health. So that involves, task shifting and task sharing and developing interventions that can be delivered by providers that don't have mental health specialty training. And so we've done a series of studies on that. And so I'll talk a little bit about that later on at the end of the workshop to give you examples. But much of what I'll be talking about draws from that experience. And with that, I will start. So today I'll give you a very, very brief overview of what dissemination and implementation science research involves. And we'll talk a little bit about some of the key models, theories, and frameworks that's often used in implementation science. And then also talk about dissemination implementation strategies that have been found to be effective for addressing the implementation gap. And then we'll end it with some examples from the research that I've been part of. So, just to give you a sense of why it is that this field started, it takes 17 years to turn evidence into routine service delivery, into real world practice. That's just much too long. What happens is that, when we develop new interventions, there's multiple studies that have to be done before they hit the real world. And, and then once they hit the real world, there's a whole process for getting it to stick in organizations and in practices. And so implementation science is really a field that grew out of this gap and this attempt to figure out ways to shorten that, because the evidence changes, with the context. And so, if it takes 17 years, by the time it hits the real world, the environment has changed. And so then we need new evidence. And this catching up is what we've been doing in the field for too long. And there's a great deal of costs related to not being able to implement evidence-based practices or implement things that we know to work. The cost includes just basically poor quality of care. People suffer more, people get sick longer, they stay sick longer. It increases disparities because people don't have access to quality care. And communities that don't benefit from there's communities that don't benefit from the billions of dollars that are already invested in research. And those communities that are in low resource settings are especially impacted. So now, with the impact of COVID, some of these rates have been even, have increased in terms of the disparities. But I'm going to talk a little bit about mental health because that's my area, and use mental health as an example for how implementation of evidence-based practices does not reach the community. So we know that pre-COVID, about 20% of the US population is impacted by a common mental health condition, and 80% of those people do not receive care. Now with COVID, we've seen rates that have doubled. So about 40%, in some studies, it's been about 50%. And we don't know what the treatment gap is now because there's been a big shift to remote delivery and a lot of practices and places are overburdened at this point. But if it was 80% before, it is probably much higher now with the impact of COVID. And so, that gap is really what we need to address in implementation science. So what is implementation science? I'm going to use the word implementation science to represent D&I, but it includes implementation and dissemination research. According to NIH, the implementation research is defined as a scientific study of how to integrate research findings and evidence-based interventions into healthcare practice and policy. Dissemination research is the study of how and when research evidence, sorry, you can't see this, the study of how and when research evidence spreads throughout agencies and organizations and frontline workers providing public health and clinical services. So basically, it's research to inform how to make the right things to do and the easy thing to do. That's according to Carolyn Clancy from the Agency for Healthcare Research Quality. I think that's a really great way to capture what implementation science is. Here are the elements of D&I research. Basically, what is included or involved in D&I research, there's always a quality gap. You're identifying a quality gap. So or an access gap. And there's, sorry. And describing what the consequence of that poor implementation is. Then there's what is implemented. So that's the evidence base. What's the evidence base for that intervention? Sometimes it's a guideline, a protocol, a treatment. Then you want to have how will it be implemented, and that covers the tools and the strategies for moving that evidence-based practice into use. And then there's a with whom will it be implemented. So that's often the healthcare provider. It could be a community health workers, champions, peers, and then in what environment or settings is the study being implemented. So healthcare, community, faith-based, school, parks, etc. The kinds of research questions we ask in D&I studies include questions like, what are strategies needed to support adoption of an evidence-based practice? Under what conditions? What are the organizational and provider factors associated with high quality implementation? What are the characteristics of effective champions for supporting an innovation? What kind of training approaches are needed to support non-specialists implement an evidence-based practice? What does it take to scale up an evidence-based practice? What are the barriers and facilitators of effective implementation? Or what are the barriers and facilitators of sustaining an evidence-based practice? These are the kinds of questions we typically ask in D&I studies. And just to give you all a sense of the research process and the kinds of studies that are done, we start out with basic science. So those are the kinds of studies that are done to, like, for example, in depression care, understanding what is depression, what are the symptoms of depression, and doing some of the basic science around what it's correlated with. Then there's efficacy studies, and these are studies that test the effectiveness of an intervention in a lab setting, so in a controlled setting. And so usually, that answers the question of in an ideal setting where everything's controlled, where the exact training people are receiving, and you control the dosing, and you control the environment, then efficacy studies tell us about how effective that intervention is under that condition. Effectiveness studies are studies that are usually done in the real world. And so that's where you don't have as much control over the supervision or the trainings and the types of providers and the settings. So it could be at a community-based organization, for example, and testing out the intervention. And still in that, with effectiveness studies, you're still randomizing. So you're comparing the intervention with usually a control. And so that tells you about the effectiveness of the program, the intervention in an environment that it will be implemented. So it's much more generalizable. Then there's like services research, which is oftentimes, research that is conducted in real world settings where they are already implementing programs and there's much less control, and it may involve a randomized control design, it may not. But implementation science research is falls within both of these areas. And it's really, the combination of effectiveness studies and services research. So this is one of the reasons why it takes 17 years, is because all of this usually happens before people get to implementation research. And each of these projects, for example, for myself, my first study took about 5 years. The next study was another 5 years. And then, so every study just takes much too long to do. And so we just need to figure out ways to begin asking implementation questions early on, even when we're thinking about designing efficacy studies. One of the issues and problems that we see with interventions is that over time there's a voltage drop. Basically, that means it's a drop in the impact of the intervention and the effectiveness of the intervention. And the reason for that is because when it starts out under more controlled settings. So if you're, for example, in an efficacy study, and so over time there's less control, and as there's less control, and especially as it moves into community, where there's it's not an ideal setting anymore because there's so many other constraints and so many other factors that impact the intervention, the effectiveness decreases. But at the same time, there are also adaptations that are made in community settings, and once the intervention moves into the real world, that increases its relevance. There are adaptations that are made that increases its effectiveness or its impact. So this is sort of what we see over time. What we want is to be able to figure out what are the elements and the factors that are needed to maintain this evidence so that we still can reach this optimal effect. And the shift between the optimal environment and the way things are implemented under optimal environment to the unintentional things that happen once the intervention moves into real world setting and has to respond to the needs and constraints that are in the real world setting usually results in what we call a program drift. And so that means that it's like changes that are happening in the intervention. For example, if an intervention was designed to be a 12-session intervention, but what happens as the intervention, is implemented in different settings is it shifts from a 12-session intervention to a 6-session intervention, or elements of an intervention aren't delivered. So those things are called program drift. And what results from that is lower effectiveness, which then also reinforce, can create a negative cycle where if the intervention isn't as effective, it also impacts the providers that are implementing it because it's, they don't see the results, and then that might make them implement it with even less fidelity. So why should we do D&I research? For the most part, it improves care. Helps us understand what are the factors that improve the effectiveness of care. It can address disparities. It helps us understand how to use the limited resources that we have and identify the factors that matter most. And so we can invest in those factors. And a third important reason is because it helps us understand what are the elements and factors that are needed to spread innovations and to spread effective ideas and practices into the real world. There's lots of different types of D&I studies. There's correlational studies where we're looking at the factors associated with implementation. There's qualitative studies that could be case studies, in-depth stakeholder interviews, observations, modeling studies that estimate effects based on evidence-based assumptions and can use a lot of the existing data that we have in health services. A lot of quality improvement data is really useful as well. Pragmatic studies are studies that examine effects using non-randomized designs, and basically that just has less control, but it's more generalizable because it gives you more information about how the interventions would live in the real world and the effectiveness of the intervention in the real world. And oftentimes, when you're working in the real world, randomization is very difficult to do. And then experimental studies are the studies that are randomized, and where we can manipulate components of an intervention or manipulate whether, certain groups get the interventions or don't get the intervention. And that's the more rigorous tests of the intervention. There's 3 types of D&I randomized control designs that are usually used in D&I research. They're called hybrid implementation and effectiveness studies. And the first one is basically where the effectiveness is the primary goal. And so it's really looking at the intervention and whether it's and by effectiveness, it means the impact on patient outcomes or client outcomes. And then there's more of a smaller part that's focused on implementation. So it might collect information about the providers or about the adoption of services or the quality of services, but it's not the primary focus. And hybrid 2 studies are studies that have an equal, put an equal weight on implementation and effectiveness. So that's, you're collecting data and you're testing both the strategy and the intervention. The third is hybrid 3, where the focus is on the implementation and then effectiveness is the smaller and de-emphasized component of the evaluation. So now I'm going to shift over and talk a little bit about some of the models and theories and frameworks that's used in D&I. In D&I research, one of the things that's really important to understand is this distinction between the what and the how. Oftentimes implementation, strategies are used in all studies and all interventions. It's just not distinguished from the actual intervention itself. And so when something doesn't work, you don't know if it's not working because the intervention isn't effective, or it's not working because the strategies that you're using or the way that it's being implemented isn't effective. And so implementation research really distinguishes these two. And this is a model that was developed by Enola Proctor, and it basically separates out the evidence-based practice from the strategy and the tools. And the other thing it does is it separates out the implementation outcomes from the service and the client outcomes. And usually in much of the intervention studies that have been done, the focus is really on the client outcomes. And so, because that's the end game, is how do we improve outcomes for the patients that receive the services or the clients that receive the services. And but then you don't know, we don't collect the information about whether the program is well received by the providers and by the setting, whether the service is done in an efficient way, or whether it's feasible. And so in implementation research, we distinguish between the implementation outcomes, which are variables and outcomes like feasibility, fidelity, acceptability, sustainability, uptake, costs. Service outcomes are outcomes related to like the efficiency of the program, whether it's safe, the effectiveness of the program, equity, timeliness. Client outcomes are outcomes such as satisfaction, functioning, health status, mental health status. A very common framework in implementation science research is the RAIN framework, which stands for whether an intervention reaches the population that you're expecting it to reach, whether it's effective, whether it's adopted, the implementation quality, and maintenance, which is essentially sustainability. And usually for REACH, we're looking at things like the proportion and the representativeness of the individuals that participate in a given program. The effectiveness is essentially the impact of an intervention on important outcomes. The adoption is the proportion and representative of whether the program is adopted by the setting or is used by the setting. And the intervention agents, which are the people who deliver the program. So the proportion of people who actually initiate the program that you're trying to introduce into a setting. Implementation quality usually refers to the intervention agent's fidelity to the components of the intervention protocol. It also can include things like quality as well. So looking at, if an intervention should have certain elements of quality, then whether that quality is reached when it's being implemented. It also covers things like adaptations that are made to the intervention and the cost of the implementation. And maintenance refers to whether the behavior is sustained over 6 months or more after the treatment is introduced or the intervention is introduced, and whether the program or policy becomes institutionalized or it becomes part of routine organizational practices and policies. But this is a really great framework for measuring whether programs are being implemented well. So the REAIM framework. This is the PRISM model, which stands for Practical, Robust Implementation and Sustainability Model. And it basically helps us understand sort of the process and the factors to think about when we think about interventions and how to move it into the real world. You have the intervention, but you have the perspective of the organization about the intervention and the perspective of the patient or the client about the intervention. And then there are characteristics of the organization and characteristics of the clients that impact the implementation. And then there's, within the organization, there's the infrastructure that supports the implementation of that organization. And then there's beyond that, the external environment. So the funding environment, other factors outside of the organization that might impact the implementation of the intervention. And all of these factors impact the adoption, the implementation, and the maintenance. And that then affects the reach and the effectiveness of the intervention. So this is a good model for looking at all the different pieces and how they fit together. The REAIM and the PRISM has been used together, and the REAIM, because it's probably the most common framework used, they did a 20-year review and they found that the PRISM model is a very well articulated model for looking at implementation because it focuses on specific contextual factors to more local and organizational factors, and focuses on the fit between the characteristics of an intervention and the implementation system. And then it's also focused on the settings, and strategies for enhancing the settings by looking at the maintenance characteristics. And so those are some of the elements that are important in looking at whether, looking at how you move interventions into the real world, and models for supporting that, really thinking through these contextual factors and how they relate to the implementation outcomes. The CFIR is also another framework that is used pretty often in implementation science research. It basically it has a lot of the same elements as PRISM. There's the outer setting, there's the inner settings. Outer setting are, things like patient needs and resources, external policies, incentives. Inner setting variables are structural characteristics of the organization, the network that the organization is part of, how people communicate within the organization, the culture of the organization, the implementation climate. And this implementation climate is actually really important because I think there's a lot more work now focused on the implementation climate for adopting innovations. Are there qualities that are in the leadership and the system that helps facilitate new ideas being implemented and disseminated? So those are a lot of the inner setting characteristics. Of course, there's the intervention characteristics, and that can tell you a lot about the fit of the intervention with the organization, the strength of the evidence, and whether it is tailored for the population that the organization is supporting. The complexity of the intervention, if it's too complex, it makes it very difficult for it to get implemented. The cost is also another very important factor. There's individual characteristics of the agents, implementation agents, and that's like the providers usually, their knowledge level, their beliefs, their skills, their sense of self-efficacy, the stage of change they're in. So, whether they want to change, whether they're motivated to change and adopt, these new innovation or interventions. their role in that process, and then, of course, other personal attributes. And then there's important factors related to the implementation process. So the planning phase, planning that's done, the engagement with the community, engagement with the client population, the execution of it, the reflection, the evaluation. So these are all elements of the CFIR framework. And it's also another useful tool for kind of thinking about all the layers that's involved in implementing an innovation or an evidence-based practice. And the CFIR has also been combined with the RAIN framework as well. And so basically, it helps us see or distinguish between the CFIR dimensions, which gives us a sense of the implementation conditions, barriers, and facilitators, like the why, it answers the why. And then the RAIN gives us the information about the who, what, where, how, and when. But basically, the elements of the CFIR helps us understand and identify the characteristics that pull the intervention so that it can impact the clients. So that's the diffusion, like how is it that how are these factors pooling for the program to reach the population that's supposed to reach. And then, if the program does reach the implementation outcomes that it's supposed to, for example, if it's effective or the quality is good, that also then pushes for further dissemination. So it actually reinforces the context or the environment to then continue to implement. So it's like a cycle that happens. Now I'm going to move over to talk about strategy. So now we've talked a little bit about what is D&I research. We've talked a little bit about some of the frameworks that's used and the language that's used to identify the components of the implementation process and the types of outcomes that are looked at. Now we're going to talk a little bit about the strategies that have been identified in D&I research. And here are some of the strategies that have been found to be effective. Of course, community engagement is a really important piece of that. Partnerships, networks, collaborations, the degree to which there's sharing of resources, sharing of perspectives, and sharing of power in making decisions about interventions is a really important strategy in moving evidence-based practices into the real world. Task sharing is an emerging area, and it's actually quite big in the global space. And so because there, in terms of mental health services, for example, because there isn't as much infrastructure in a lot of low and middle income countries for mental health services, there's been a need to develop task shifting strategies. So that usually involves simplifying interventions so that the components are more easy to train people who don't have the specialty background. And so there's a lot of task sharing that happens in HIV care, in maternal health, and in mental health as well. And so things like simplifying screenings or the assessment process and simplifying intervention. So instead of a 12-session intervention, it's now a 4-session intervention, and the skills are really clear, and there's manuals to support the intervention. So that's usually the types of the strategies that are used in task sharing and task shifting. And task sharing basically refers to the sharing of certain tasks so that so it's not only implemented by a new type of provider, but is usually shared with the specialists. And then there's, of course, like the introduction of navigators to help people move through a care system. And that also oftentimes involves the use of peers, for example, or the use of community leaders. And that's been a strategy that I think is gaining a lot of traction, especially in the mental health space. Learning collaborative is a type of quality improvement process, but it basically can be a combination of community engagement with strategies for developing systems of problem solving, within the organization and across different different implementers. So there's a lot of leveraging of peer learning and leveraging of strategies that are used by different organizations and different types of providers. And so it really moves the training and the reinforcement of the training outside of the trainers, and allows for more space for the kind of learning that happens in the real world, because there's so many solutions that are, and innovations that come up that, don't make it into the research space, but, are in the out in the field. And so the learning collaborators really can tap into that and leverage that. There's also something called the PDSA cycle, which is a quality improvement process that basically allows people to plan, to do, to act, and to study small changes to an intervention, or small changes to strategies that are being used. And that's a really key part of learning collaboratives, and that seems to be really helpful because it creates a process for evaluation of changes that are made to an intervention and testing to see if they work, and then learning from that process. There's also, a lot of work in the training and the supervision space, in terms of training. There's models like train the trainers, and, creating a stepped process so that you're training certain types of providers first, and then supporting them to then train the next group of providers. That's really helpful because it can help organizations develop champions within their organization, and it helps decrease the reliance on external trainers and external specialists outside of the organization, which can help sustain the intervention and also improve the implementation quality. Then in supervision, in some of the work that we've done, we've really made the supervision process much more structured, where we provide a lot of tools for supervision. So specific things for supervisors to evaluate or to pay attention to, and an integration of outcomes, and looking at outcomes on a regular basis, and also creating a system for monitoring. And so sometimes that feeds into the quality improvement process. There's a lot of new developments in the technology space. EHR is really important for tracking outcomes and for communicating across different types of providers. There's lots of new apps that are being developed and tested, online tools for training, online tools for intervention, online tools for sharing of data. So these are strategies that are often used in D&I research. I'm going to talk a little bit about some of the work that I do, and sort of provide you a little bit of an example of how we moved from effectiveness studies into implementation science studies. So we started working in Vietnam in 2007, and during that time there was very limited mental health services available to the community. And so what we wanted to do is build the capacity of primary care clinics to deliver mental health services, and specifically depression care. But there was a lot of concern about implementing mental health services in primary care, because there's very limited training that's provided now, or actually no training in the cases in the settings that I worked in. And so we had to figure out a model for supporting primary care providers, and we created this mobile like support system where psychiatrists and psychologists from a local psychiatric hospital would go out into the primary clinic and provide the supervision. So creating a collaboration between the psychiatric hospital and the primary care clinics. And the primary care clinics in Vietnam were sort of the first point of contact for most people into the healthcare system. And so we figured that if we can develop capacity for people who are gatekeepers to the healthcare system, we could basically increase access to mental health services, but also reduce the bottleneck that we see in psychiatric hospitals. And so that first set of studies was really designing that intervention and creating the model for it, and testing whether that works compared to just medication. We did a randomized control study. We found it to be very effective. Rates of reduction were in the 80 percentile. So it was very highly effective, but we had a lot of supervision built into that program. And then, but what we also found was that when we were implementing that program, there was a really high dropout at the beginning of the program because the population we worked with was really poor, and also, were mostly in rural areas. And so there was very low awareness about depression, and also not something that people saw as priority because they were really struggling with putting food on the table. And so we combined the program with microfinance loans. So that's another implementation strategy, is to integrate the program with something else. And we repackage the depression care service so that it can be delivered in a way that does not feel like mental health service. And so that modification happened next. And so that program is called the Life DM program. We did a controlled study on that and found that to be effective. Then the next set of studies was really focused on developing a model for scaling up the service. And so that program, or that study, is really focused on figuring out what are the levels and the layers within the system that we needed to train, and creating a tiered process of training, and then testing out and trying out the learning collaborative approach, and developing champions, developing leaders within the system, so that when we step out, it can be adopted by the system. And so that is the Lifetime Transition to Scale study. We just finished that, and that also was found to be effective, but there was no control for that. So we're just looking at pre and post and comparing the outcomes that we were able to achieve once the training transitioned to the local teams. And we found that the effectiveness was, comparable to what we did when we were the ones providing the training. The current study that we're doing now actually randomizes the early depression care project. So the one that was done in 2007 and 2009. So that's just the basic depression care program. We randomized 36 communities, so 36 sites, to 3 different implementation conditions. So the first is basically workshops and technical assistance, which is the typical way programs are scaled up in Vietnam and probably around the world as well, because it's less resource intensive. Workshops, giving people toolkits and providing some limited technical assistance. So that's our first model, and that's basically our control. We don't think that that's enough to sustain programs and to get programs to be implemented with fidelity over time. And so the second condition is the condition that we've been using across all of our project, which is the condition that includes the supervision. So it's workshop, toolkits, resources, plus ongoing supervision for 6 months. And the third is one where we added a learning collaborative. So this set of study is basically randomizing communities to the 3 different implementation conditions, but they're all implementing the same intervention. So that's an example of sort of like how a evidence-based practice can transition and be implemented in different ways, and how you test out different questions over time. And so this is another display of it, where the first is this is multi-component collaborative care for depression intervention, and we compared that to just medication. Then we added a new component to the intervention, so that's the depression care plus the livelihood component, which is the microfinance loans and teaching people livelihood skills and supporting livelihood goals. And so then the third is basically testing using the supervision approach, the enhanced supervision approach with the learning collaborative. This is community engaged learning collaborative. That's what SELC stands for. And the current study we're doing now is where we're taking the intervention and then we're comparing the different implementation models. And this is just us outlining the different things that are changed in the intervention, in the settings, in the providers, in the training, and in the supervision. And so this way, when you distinguish these parts, it's then easier to figure out what was changed and then potentially estimate what the effects are from these changes. So if you're changing or adding different types of providers or different components to the training, this gives you an example of just the livelihood intervention that we did, the LifeDM program, and what it looks like. This is a 12-session group intervention that teaches mood and stress management, also teaches problem solving around depression as well as livelihood challenges. A small microfinance loan of $150 that is used to support small businesses. So this is an example of one of our participants who sells noodles in a noodle stall, and so she used the loans to purchase equipment for her noodle stall. There's a lot of practicing of livelihood skills, and that are also depression skills as well. For example, we often ask our group members to do things like go to the local market to do research on who else is selling what you're selling and how much are they, what are they doing that's different from what you're doing, and are they successful, and and I talk to them about what they think is helping them be successful. And so that for them is a way of getting information about what they want to do, or what their livelihood goals are. But it's also a way of engaging and interacting and developing interpersonal skills. And so it addresses both the mood, the mental health issues, as well as the livelihood issues. And so this is an integration method that we use in our intervention. There's a lot of community engagement. This is a training that we did. There's a lot of dancing, a lot of singing, a lot of really activating people so that the skills that we teach in the intervention are also skills that we use as we provide training. There's a lot of support for groups, and this is a group that decided to use their loan money to purchase the materials needed to make these brooms. And during the group session, they would make these brooms and basically sell the brooms, and that was part of their livelihood plan and goal for the group. But all of these groups are implemented slightly differently because we built in more flexibility into the program. And but this is, a lot of this comes from lessons learned from previous implementation and then testing out elements of it. And so that's sort of how we've evolved and how we figure out what implementation strategies to use and what to test. This just is examples, more examples of the livelihood activities that they do. This is a participant that's selling her produces in the market. And with that, that's it. Does anyone have any questions about the presentation?
You're happy to either put that in the chat or to raise your hand and I will unmute you. We have a note here that says, excellent presentation. Thank you very much. You do have a question from Facebook asking about cultural competency and where cultural competency plays a role in the structure.
That's a really good question, and I'm sorry for missing that, because to me it's part of everything, so I don't really have it as a separate thing. But I think certainly in the community engagement part, it's really important, and it's actually where I think that the community engagement strategy is sort of where all of that gets developed and thought about and identified. But it plays out, I think, in everything.
You have another question. Are there going to be new and future projects coming up? And specifically in New York, somebody just added.
Yes, thank you for that question. Actually, Deborah and I are working with the Harlem Congregation for Community Improvement to develop something very similar for Harlem as well. So we are we're actually in the process of doing a needs assessment right now to understand residents in Harlem and the CBOs in Harlem, as well as the faith-based organizations, to figure out what are the needs, what are the resources. And from there, we will take what we've done, what we've learned overseas for the Life DM project and program, and adapt it so that we could leverage the economic empowerment strategies that are already being used in Harlem. And we'll also do a learning collaborative in that project and have, create a community network to, to basically develop collaborations around that kind of implementation, and to make sure that we, develop the program so that it's responsive to the community needs, and we identify the implementation barriers early, in the program, as well as, have a mechanism for supporting the dissemination of the information that we learn from the program and the study. And so we will be probably finished with the needs assessment in the summertime. We have submitted a grant to develop the intervention and to implement it in housing developments and faith-based organizations in Harlem.
Thank you. You have another question. Can you discuss the implementation, measurement variables, and are there any gold standards, resources you can direct us to?
Yes, the RE-AIM framework, I think, is a really good one. There was a 20-year review, and it's in the slide itself. There's a reference for that. And so I think, Deborah, you'll share the recording of the slides. And so it should be in there. The references are in there. The CIFAR and the PRISM are also two other ones that are really useful, but the RE-AIM is a very common measurement framework, and CIFAR has a website that is also listed in the slide on CIFAR that has the indicators for those variables and the outcomes. And it also has like interview guides. It has recommended tools to use. All of that is on their website. It's a really comprehensive and a really great resource.
And when we send out the link, I will pull those resources out and add them to the email so that you're able to access them easily, to make your life a little easier, if that helps.
Mm-hmm. Are any of you already engaged in implementation science research? And what are some questions that are important to your organization?
So you do have one more question here, which is, do you have recommendations as to how to initiate an implementation study from within a human service organization, especially in the case that there are programs underway where we may want to study using these models?
Yeah, that's, I think, in terms of recommendations, I think to initiate a program, having your questions, knowing what it is that would be most useful for your organization is really helpful, because then that helps frame the study so that it is a study that is responsive to your needs. And then thinking about who are the stakeholders that are needed to think about how to, move that intervention, or how to, get that intervention to be sustained within your organization, and getting their perspective would be important as well in terms of being involved in the study. And then, of course, if you have access to a research collaborator, that's very helpful, because then they can help you think about, the kind of data you already have, so that you're, not putting, you're leveraging what has already been done within your organization, or what you have access to, without having to do new data collection. And sometimes that is also necessary, but it's really helpful to look at what already exists and what you have, or, if there's a question that you have that has already been done elsewhere, then it's useful to see what has been done and what has been effective, and that can help inform the work that you do. But I think that in terms of next steps or recommendations, I'd say, know what's important to your organization, figure out what those questions are from the perspective of the key stakeholders involved. And then in terms of developing collaboration, we are very lucky that for the Harlem community, we have Deborah, who can help make those connections between the community and researchers at CUNY-SPH. But you can also just identify people, yourself, if there's people within our school that might have areas of expertise that relates to the work that you do, and initiate a conversation there.
So Dr. No, in your last few minutes, we have another comment here that says, I'm on this webinar to see how I might look for opportunities to initiate a program. Do you have any parting insight that might help our participant in thinking through what that would look like?
Yeah, I'm wondering if there's if organizations have a need to evaluate certain things, certain aspects of their program, if we could figure out a way to create a sort of like a list or a shared space for that, where it can get communicated, and then we, like a matchmaking service, for community-based organizations and academic partners. And then that way there could be some sharing across the two. And I think it's many ways you serve as that person, Deborah, for Harlem. But I wonder if we can start there, and then anything outside of Harlem, we could bring it back to the school and see if there's a way that we can facilitate that kind of matchmaking. I think that that could be something that would work. And
I'm happy to do that, and I'm happy to utilize the Harlem Health Initiative to assist those in Harlem, and also citywide. We can definitely work on that, and you're happy to reach out to me. You do have another question here. I'm trying to include preliminary D&I variables in a feasibility study, with understanding that funders are now expecting that we are looking ahead. But is it challenging to identify which indicators to include with so many realms to consider?
Yeah, you're right. There are a lot of variables there. And it's difficult to do if it's, but in a feasibility study, I think it's useful to look at a range of variables so that you can figure out what you want to focus on for the next study. But it's probably, has to do with feasibility, like what's going to be easy for you to collect and have access to, what is most changeable. Sometimes there are things that we are not able to change. And so if you are collecting information about things, about factors that you can't change, how useful is that going to be for you? So I think in terms of, thinking about what you have access to, what is feasible for you to collect, and then, what are the processes you want to make change to, and then prioritizing those factors.
Are there any other? Yes, so that was very helpful. Thank you very much. And so I'm going to ask in our last few minutes, Dr. No, if you have any closing thoughts. I have in the chat included a brief survey. This is just to help us better understand what your needs are. So please, if you have an opportunity to please complete that as we are finishing out. But Dr. No, do you have any parting thoughts that you would like to share with us?
Yeah, I think that implementation science research that comes from the community, that comes from the frontline, organizations that are actually doing this work are the best studies. It really should be driven by the needs in the field versus areas that are of academic interest to researchers. That's not as useful. So actually the questions that you all have asked, and especially for those who are thinking about, things in terms of questions for programs that they're interested in implementing or already implementing, and trying to figure out whether those are effective, and strategies for improving the effectiveness. That's really where the field needs to move to. And so having the organizations that are on the front line be more centrally involved in the implementation science research world, I think will make implementation science research much more relevant and more impactful. So I highly encourage you all to do that, especially because so many organizations probably have so much data already that is untapped. And that's just, for many researchers, that's like a gold mine, and so they would be happy to work with you because you already have so much information. And, if there's a way for you to figure out what you need that could be, helpful to improve programming or improve, your organization, then I think many researchers would be happy to participate and to collaborate.
And I will put a shameless plug in for the school here. Knowing that you have all this data, here is a great opportunity to engage our students in field placements who can help you work with that data. And so think about that, having one of our graduate students be a part of your organization to help work on that. That would be a fabulous way. Is there anything else, Dr. No? I want to just take this opportunity to really thank you. It is really an honor and a privilege to have you be a part of our skills building webinar series. I can't thank you enough for imparting the information that you've shared with us. I want to thank each and one of our participants for taking the time to come and share this hour with us. We will be continuing to provide skills building webinars throughout the year. So please look for us on Facebook and on Instagram and on LinkedIn. And if you have ideas about things that from a public health perspective you think would be important for us to highlight during these skills building webinars, please reach out to me. I will leave my information in the chat. And once again, thank you, Dr. No, for all that you do for our community and helping us.
Thank you for having me. This is really fun.
Thank you all. Have a great day, and please fill out, we'll stay online for a bit longer, but so that you can complete the survey. Thank you again and have a great day.
And I'll be available for a few more minutes if anybody wants to chat.